Bulimia nervosa, presented by Sarah, Justice, and Paola.
The Diagnostic and Statistical Manual of Mental Disorders, 5th edition, has 4 criteria for diagnosing bulimia. 1. Binge eating occurs at least once a week for 3 or more months. 2. There is a loss of control over binge eating and an avoidance of weight gain. 3. There is a use of laxatives, diuretics, enemas, restrictive food intake, or excessive exercise. 4. Evaluation of oneself will be influenced by body weight and shape.
The American Academy of Pediatrics Committee on Adolescence classifies bulimia into 2 different subcategories. The first is purging, which includes regularly engaging in self-induced vomiting or the use of laxatives or diuretics, whereas non-purging includes the use of other inappropriate compensatory behaviors such as fasting, hyperexercising, without the regular use of vomiting or medications to purge.
Incidence and prevalence. 2.6% of women have bulimia at one point in their life. An additional 10% or more have symptoms of bulimia but do not classify as bulimic according to the DSM-5 criteria. And 10% of people that suffer from bulimia are men. Key numbers in recovery. 45% of bulimics make a full recovery. 27% make a considerable improvement, and 23% make little or no improvement.
According to the Academy for Eating Disorders, an individual may present with a variety of signs and symptoms, and no 2 patients will be the exact same. General signs to look out for include changes in weight, including weight loss, weight gain, and overall fluctuations in the weight, weakness, dizziness, or syncope. Cardiorespiratory changes include chest pain, palpitations, arrhythmia, shortness of breath, or orthostatic changes, meaning that when a person goes from sitting to standing, there are large changes in the heart rate or blood pressure. Patients with bulimia tend to also experience quite a few gastrointestinal symptoms, such as abdominal pain, gastroesophageal reflux, which is acid reflux, constipation, which leads to hemorrhoids, as well as vomiting blood due to purging episodes. Symptoms related to the endocrine system include low bone density, loss of libido, and in some cases, irregular menses, as well as the loss of having a period altogether. Some neuropsychiatric conditions include seizures, difficulty concentrating, changes in sleep patterns, as well as depression, anxiety, or obsessive behaviors. Patients with bulimia are also at a higher risk for suicidal ideation, as well as self-harm or suicide attempt. Other signs and symptoms to look out for include oral and dental trauma, lacerations to the mouth sores, dental caries, or something called permolysis, which is a form of dental erosion that is not due to bacteria involvement and instead has to do with the multiple purging episodes that is characteristic with most bulimic patients. The first photo demonstrates some photos of the discoloration in dental caries caused by multiple purging episodes. Other key symptoms to look out for include hair loss, dry skin and hair, discoloration of the skin, as well as something called lanugo hair, which is a fine peach fuzz kind of fur that grows on an adult body that is severely malnourished, such as those with anorexia nervosa or bulimia nervosa. Another key symptom is something called Russell's sign, which is a callus over part of the hand or knuckle, which is a result of multiple purging episodes. The middle photo is an example of the lanugo hair, and the last photo is a picture of Russell's sign, and you can see the callus on the knuckle.
Some of the emotional symptoms associated with bulimia nervosa are having low self-esteem, depression and anxiety that can contribute to social withdrawal, getting frustrated over little things, and feeling guilty or shame when eating, as well as fearing weight gain. 4 psychological factors that influence bulimia nervosa are low self-esteem, depression, trauma, and anxiety. Having low self-esteem influences bulimia nervosa due to the lack of confidence and inaccurate negative body perception of themselves, which leads to unrealistic body goals and ways of reaching that goal. Some of the ways in which they try to reach this body goal is through extreme diets, starving themselves, and excessive exercise. These behaviors lead to obsessive thoughts surrounding their body and food after continuous failed attempts to achieve the goal. So they engage in binging episodes to get a sense of relief and control that occurs during the binge. Depression is another psychological factor that contributes to bulimia nervosa and can often go hand in hand with having low self-esteem. Individuals with depression experience feelings of guilt, loneliness, and low self-esteem, which can lead to disordered eating habits to get a sense of control and escape from what they're experiencing. Experiencing any form of trauma during childhood increases the risk of developing an eating disorder like bulimia nervosa. Individuals that have experienced trauma tend to use avoidance as a coping mechanism to reduce the negative feelings and thoughts associated with the traumatic event they experienced, whether it was recent or long ago. During a binge, the awareness to reality is lowered, offering these individuals a mental escape for the time being. After the binge is over, the feelings begin to rise again, which causes them to feel worse about themselves and leads to another binging episode to minimize these feelings. Anxiety is another factor that contributes to bulimia nervosa, with social anxiety being one of the 2 most common types of anxiety among bulimic patients. Social anxiety forms from the continuous pressure to achieve an ideal weight. This is often the result of someone who has experienced the expectation of perfectionism during childhood. Controlling their body or weight gives these individuals the sense of control over something. Family is a social factor that contributes to bulimia nervosa. The relationship the parents have with food influences the relationship the children will have surrounding food. Having a parent that is weight obsessed can negatively impact the child by influencing the child into believing the same narrative and engaging in behaviors to change their appearance to what they think they should look like. Making comments based on appearance can also make the children become self-conscious, causing them to lower their self-esteem, which can lead to bulimic behaviors. Along with comments on appearance, getting bullied, especially based off appearance, is another risk factor to bulimia nervosa. According to the National Eating Disorders Association, 65% of those with an eating disorder say that bullying contributed to it. Getting bullied on appearance can cause body dissatisfaction, resulting in the engagement of disordered behaviors to quickly change their appearance to fit the mold of what they think they should look like. With social media becoming more common, many of the bullying has turned into cyberbullying, which has a greater impact on the individual due to the harder comments. Cyberbullying causes depression, social anxiety, changes in self-esteem, which all contribute to developing bulimia nervosa.
Clinical studies have demonstrated that patients with bulimia nervosa consume significantly more food, however, feel less full after eating compared to the control group when the meals were provided in a laboratory setting. The sense of feeling full is determined by specific chemicals, including cholecystokinin, which is released in the upper gastrointestinal tract post-meal consumption. These chemicals then signal the brain to stop eating and result in feeling full. According to a study published in the New England Journal of Medicine, there are lower plasma levels of cholecystokinin in bulimic patients than in control groups. As a result, patients with bulimia nervosa tend to feel less full after consuming a meal and increase the risk for disordered eating. Generally, studies have indicated that genetic factors account for 40 to 60% of susceptibility to bulimia nervosa. The lifetime risk among female relatives of an individual with an eating disorder are estimated to be 7 to 20 times higher than that of the general public. There is strong evidence indicating a genetic component. However, researchers are still trying to disentangle the biological influences from the environmental and sociocultural factors.
Sociocultural factors. Dissatisfaction with body image is a key element with bulimia. Many cultures do not face issues with dissatisfaction in body image until introduced to the Western ideal of beauty standard for women is for them to be thin. Cultures with a strong sense of self-identity, such as African American women, have less issues with dissatisfaction of their body image. For example, their dissatisfaction rate is 30%, and therefore there is less risk of them becoming bulimic. White women and other ethnic groups that follow the beauty standard of thin women have higher rates of dissatisfaction, as high as 80% dissatisfaction in their body image.
Studies have demonstrated that antidepressants can help treat patients with bulimia nervosa by reducing binge eating and purging behaviors, even if the patient was not diagnosed with depression before. Cognitive behavioral therapy helps replace disordered eating habits with healthy ones and develop a sense of control. Identifying common triggers and developing healthy coping mechanisms for stress helps aid with recovery. Exposure therapy also helps by exposing an individual to potential triggers and helping them overcome their fears to prevent a binging and purging episode, which has been proven to improve long-term outcomes.
Treatment. The treatment option of hospitalization usually occurs when the person's symptoms become life-threatening or have interfered in their daily life in a drastic way. Hospitalization can also be referred to as inpatient programs or a recovery center. When doctors or family members have determined that the patient needs constant observation, whether it is due to the physical symptoms or the patient being a danger to themselves, the hospitalization can become voluntary or involuntary. Hospitalization may include treatment through both medication and therapy. Outpatient programs follow the guidance of doctors. Patients carry on with treatment and coping mechanisms while carrying on their daily lives, while having the extra structure of doctors in the program devised to assist recovery.